السلام عليكم ورحمة الله وبركاته. أنا دكتور احمد عبدالبديع، مدرس أمراض النساء والتوليد، كلية الطب، جامعه اسيوط. أنا بحب أشكر دكتور سيف الإسلام والزملاء والأساتذة الأفاضل المشاركين في البرنامج. Today's lecture is about the investigation and management of the small 4 gestational age fetus, a simplification of the green top guideline from the Royal College of Obstetricians and Gynecologists. Today is the first part of this lecture. To provide your patients with quality standard of care, you have to follow a guideline in your practice. There are 2 major evidence-based medicine schools in the field of OBGYN, the American College and the Royal College. To start the practice of evidence-based medicine in your institution, follow a guideline and document it as a source with all your clinical decisions, and others will follow the same practice as you keep doing it. I'm not a fetal medicine specialist, but my goal here is to simplify some of the Royal College guidelines directed to OBGYN specialists. Our lecture will include the definitions, the screening, the diagnosis, investigations, prevention, fetal surveillance, time to deliver, and mode of delivery. To start with the definitions, as you can see here, there is a 10th centile. Okay, there is a 10th centile here, and below it is a small 4 gestational age, and there is a 90th centile, and above it is a large 4 gestational age. Between the 10th and the 90th is the appropriate 4 gestational age. And if we look at the left side of the graph here, we can see if the baby is delivered and its weight is below 2,500 grams, it's called low birth weight. So, regarding the definitions, small 4 gestational age mean that by ultrasound that the estimated fetal weight or the abdominal circumference are below the 10th centile. And for severe small 4 gestational age, the estimated fetal weight or the abdominal circumference are below the 3rd centile. So small 4 gestational age, it includes 2 categories. One of them is constitutionally small, which comprises about 50 to 70%, and they are fetal growth appropriate for the maternal size and the ethnicity of the mother. And the other category is the fetal growth restriction, which is higher in severe small 4 gestational age infants, and it implies a pathological restriction of the genetic growth potential. And those fetuses usually manifest with fetal compromise. So the small 4 gestational age, as we said, is divided into 2 categories: the constitutionally small and the fetal growth restriction. The fetal growth restriction is further subdivided into non-placenta mediated causes as structural or chromosomal anomaly, inborn error of metabolism, fetal infection. And the other category is placenta mediated as malnutrition, substance abuse, preeclampsia, diabetes, severe anemia, or autoimmune diseases. The second part is about screening for small 4 gestational age. So usually you see your patient as a booking appointment between 8 to 12 weeks, and this is the appointment where you are going to take a thorough history, do a clinical examination, draw some blood investigations, urine test, and do an ultrasound. appointment, you have to screen for small for gestational age. You have to look specifically for risk factors. The minor risk factors are maternal age above 35, IVF singleton pregnancy, nulliparity, body mass index below 20, body mass index between 25 and 34.9, smoker less than 10 cigarettes per day, low fruit intake pre-pregnancy, history of previous preeclampsia, or a pregnancy interval less than 6 months or more than 60 months. These include maternal age above 40, smoking more than 11 cigarettes per day, paternal small for gestational age, abusing cocaine, daily vigorous exercise as in athletes, previous small for gestational age baby, previous stillbirths, maternal small for gestational age, chronic hypertension, diabetes with vascular disease, renal impairment, antiphospholipid antibody syndrome, heavy bleeding similar to menses, pregnancy associated plasma protein A less than 0.4 mean of median. If you look at the end of the green top guideline, you'll find a summary of the risk factors, the minor and the major, with the regression models results. So as you can see here, look at the odds ratio. So they divided whether they are minor or major based on the odds ratio. If the odds ratio is above 2, then it is major risk factor. As you can see here, for example, maternal age above 40 is considered a major risk factor because its odds ratio is 3.2. So in your booking assessment, you screened for the risk factors and you documented them in your medical records. And if you find 3 minor risk factors or 1 major risk factors, you're going to take a closer look during the 20 weeks reassessment. There are other risk factors that you have to consider when you are evaluating your patient at 20 weeks. In some centers, they do a screening for Down syndrome. So whether the screening is for structural anomalies like by ultrasound, you may find a fetal echogenic bowel, or you're doing a biochemical screening, you have to look at the result of pregnancy associated plasma protein A. If it is less than 0.4 mean of median, this is considered as well as a major risk factor. So after you reassessed your patient at 20 weeks and established the risk factors available, you have to decide what are you going to do. If you find that there are 3 or more minor risk factors, you have to start with doing a uterine artery Doppler between 20 and 24 weeks. If you find this Doppler is normal, then you will see the patient again in the 3rd trimester and do an assessment of the fetal size and the umbilical artery Doppler. However, if you find the uterine artery Doppler abnormal, then you have to proceed with serial assessment of the fetal size and umbilical artery Doppler from 26 to 28 weeks. And if you find 1 major risk factor from the start, you will skip the uterine artery Doppler and you will proceed by a serial assessment of fetal size and umbilical artery Doppler from 26 to 28 weeks. Also, if you at 20 weeks you're starting doing clinical examination and you can not properly assess the fundal level or cannot estimate the symphyseal fundal height, then this also considered as a risk factor that you should start serial assessment of fetal size and umbilical artery Doppler from 26 to 28 weeks. So just to elaborate a bit about abnormal uterine artery Doppler, abnormal means that the pulsatility index is more than 95 percentile and or there is notching. And this signifies that the flow velocity ratios are associated with inadequate trophoblast invasion of the myometrial spiral arteries, which means there is inadequate blood supply reaching the fetus. So after the 20 weeks assessment and you decided on your plan of management, you're going to reassess your patient again in the third trimester, as we discussed in the algorithm. However, also if you find certain risk factors in the second or the third trimester, you have to be vigilant and starting serial assessment of fetal size and umbilical artery Doppler. So specific risk factors include severe pregnancy-induced hypertension, preeclampsia, unexplained antepartum hemorrhage, and abruption. So the second thing you're going to do is clinical examination. Clinical examination itself is not accurate, but it starts with ultrasound assessment in the second trimester. There are two methods of doing it. One is abdominal palpation by measuring the fundal level starting from 24 weeks. The second method is measuring the symphyseal fundal height by measuring tapes and comparing it to customized charts. And as I'm stressing, clinical examination alone should not be used as a method for detecting small for gestational age. So to sum up today's lecture, we talked about the definitions and the screening for the small of gestational age. You'll find this algorithm at the end of the green top guideline. So as we said, you start from the booking assessment here. Start from the booking assessment. You look for your risk factors. You define whether there are 3 minor risk factors or 1 major risk factor. You do your reassessment again at 20 weeks. If you find 3 or more risk factors, you're going to proceed with uterine artery Doppler. If normal, then you're going to see your patient at the third trimester. If abnormal, then you're going to proceed with the serial assessment of fetal size and umbilical artery Doppler from 26 to 28 weeks. If you find that there is 1 major risk factor, then you're going to skip the uterine artery Doppler and proceed to serial assessment of fetal size and umbilical artery Doppler from 26 to 28 weeks. With certain risk factors, you find them in the second or third trimester, as severe pregnancy-induced hypertension, preeclampsia, unexplained antepartum hemorrhage, placental abruption. Then you have to start screening by assessment of fetal size, serial assessment of fetal size and umbilical artery Doppler. This concludes today's lecture. Thank you for your attention and looking forward if there are any questions.